Our next panel is going to go exactly into what we can do at European level, making colorectal cancer screening work across Europe, what needs to be done. And that's going to be introduced by Dr.Partha Basu, who is the head of the screening group for the International Agency for Research on Cancer, IARC. Dr. Basu, can I invite you to take the floor, and then we'll have a panel to discuss it. Thank you to our earlier panel, and Dr. Basu, over to you.
Thank you so much, Tamsin. It is great to meet you again. Now, very recently, this study came out that looked into the impact of colorectal cancer screening in the European context over the last 20 years. You know, the message is very, very clear. There is a heavy price to pay for inaction. Look at Germany, which started its colorectal cancer screening on an opportunistic basis, high volume opportunistic total colonoscopy based screening, started in 2002. Over the last nearly 20 years, on an average, they are seeing a decrease in mortality over 2%. And similar thing we are seeing in Austria, even in Czech Republic, which introduced screening 10 years back. On the other hand, if you look at the lower rows, Bulgaria, Estonia, or Ukraine, that have not yet been able to introduce colorectal cancer screening, there is rising incidence of colorectal cancer still, and the mortality, there is no impact over so many years. Another very interesting message that came out of this publication was that the impact of colorectal cancer screening is obvious very soon. On the left-hand side, you can see the curve for colorectal cancer screening incidence, as well as, colorectal cancer incidence, as well as colorectal cancer mortality for men and women, which of course has seen a gradual decline over the last 2 decades. Look at the curve from Netherlands or Slovenia that introduced feet-based screening relatively later. But then immediately as you introduce screening, you expect that there will be more number of cases will be detected. So you can see the incidence goes up, and see the very rapid reduction in the incidence that happens over the over few years. So again, the message is do something. Do not neglect screening. So this particular publication is extremely important to give this very strong message to the countries that are still sitting on the fence. In 2017, we published the second European screening report. Of course, it is time to publish the next one. But even in this report, we have seen that there was significant improvement in the rolling out of colorectal cancer screening across the European Union countries. So much so that 72% of the EU residents aged between 50 to 69 years, they had access to colorectal cancer screening. But then when we deep dive into the data, the huge variability is quite obvious. You know, this is showing the screening coverage by the program specific age range in the population-based screening programs. This data is again old, around 2013, 2014, this data was collected. But then first thing is, on an average, we can see 25% of the age eligible men and women in EU, they were covered. And more important is we can see a huge variability in the coverage across the different member states. Again, the same thing is quite obvious when it comes to participation rate. What is participation rate? Participation rate is out of those invited, what proportion of men and women they participated in colorectal cancer screening. What is generally we find is, fit test is more acceptable to women, and then it is, when it comes to colorectal, when it comes to colonoscopy screening, it is less acceptable to women. But again, you see the variability and the suboptimal participation rate across different countries having population-based colorectal cancer screening program. In this particular graph, I'm looking at the gap in information. This is the information around about colonoscopy compliance for the fit positive men and women. Of course, Austria and Poland, they have colonoscopy-based screening, so we don't expect any data. But still, you can see Croatia, Cyprus, and some of the countries that do not have the data of downstream management, or the colonoscopy compliance is low in many of the countries, or there is a possibility that it is really not that low, but then the data quality was poor. And this is again more obvious when we look at the detection rate of disease. It is advanced adenoma detection rate per 1,000 population screened. And you can see many of the countries, they could not provide data on the downstream management of the men and women participating in screening program. So until and unless we have a strong health information system collecting data across the full continuum of cancer screening, it is extremely difficult to ensure quality assured cancer screening. Of course, we are now facing the worst public health crisis of our generation. More than 5 million people have succumbed to COVID, but then we'll have to look at what is its impact on cancer screening. Of course, in the previous session, we learned from many excellent speakers talking about the impact of COVID on colorectal cancer screening in different European countries. And this is again another interesting publication that is based on modeling studies. First and foremost thing is that if there is a disruption in screening activities, the impact is highest on colorectal cancer, essentially because number one, it's the natural history of the disease, and number two, the screening frequency is less. And you can see out of these, out of breast cancer, cervical cancer, and colorectal cancer is worse affected in terms of the excess mortality that will happen because of the disrupted screening programs. Now, what are the solutions? IRIS has very clearly shown you that if we can have a system where we can manage to continue screening after the disruption as before, and also try to catch up those who missed screening during the disruption period, that is the best opportunity. I mean, that has the best impact in terms of avoiding this, the deaths. As you can see in the graph here, the last bar is almost like coming to zero. But then that has implication on the programs having enough capacity to handle the situation. Interestingly, there is another option that this particular modeling study came up with. It is that if we continue after continue screening for the same number of months for which the delay occurred after the stopping age. So for example, if there is a delay or there is a disruption for 6 months or 12 months, instead of stopping screening at the higher age of 69 or 74 years, we extend the screening for another 6 months or 12 months. That way, we will provide opportunity to many men and women who missed screening, and that way we can reduce the impact to some extent. I mean, this is the second best option that this particular modeling study found. And then, as Professor Logan very clearly mentioned, that this is the time to build back better our cancer screening programs. With the help of 25 global experts on cancer screening using a Delphi process, we tried to identify what exactly do we mean by well-organized cancer screening. And then through this Delphi process, we came out with 13 different criteria that a screening program needs to fulfill to be fully organized. But then when you break this criteria across the different, the 6 building blocks of, health system, it is quite obvious. Having better organized screening program is having a more stronger, resilient health system. And that is exactly this particular infographic that came out of our study showing. And finally, we must also keep in mind that even in young men and women in the European region, colorectal cancer is increasing because of lifestyle changes, and prevention should also remain in focus. Thank you very much for your patient listening.
Thank you very much, Dr. Basu, and particularly for setting out some clear messaging on what we could do about this and how we could take it forward. Extremely useful, practical, for example, just extending beyond the age cutoff by the same number of months as the disruption happened allows some catch up, and it means we don't have to rely on a surge capacity for screening, which we clearly don't have. So I'm delighted to introduce Professor Luigi Ricciardiello from the UEG, John F. Ryan, the Director of Public Health from DG SANTE of the European Commission, and Dr. Tit Albreht, the Head of the Centre for Healthcare at the National Institute of Public Health of Slovenia. So these are our panels, and we need to now discuss a little bit more on what we could do to take this forward and how we can ensure that we can share the good practice. And we had some messages from the previous panel and also from Dr. Basu talking about we need to share information, we need to share modeling, we need to share awareness, we need to share experience on what's working, and also be able to track the different tweaks that countries make to their programs, what's working better and what's not working. So let me invite Professor Ricciardiello from the UEG to first speak with us. What's the coordination that needs to happen at European level to make sure that we've got the best of all of our systems that can be shared and we can be leveling up as part of our Build Back Better process?
Well, thank you very much. And thank you very much for inviting me to this meeting. I think this is very important. So what we have heard also from Dr. Basu, we have situations where colorectal cancer screening are in place. So there are situations where colorectal cancer screening are not in place. You have situations where the uptake of the screening programs have gone down, and this is not just because of COVID-19. Of course, COVID-19 has caused a lot of disruption. So in my opinion, I think working unified using the specialist societies, making sure that we work together with our patient organizations and providing the bulk of information that colorectal cancer screening literally reduces the incidence and the mortality. And these are the data that we have already heard for many years, especially in those areas where the screening programs have been implemented. This is a key point that we need to stress our policymakers. So in my opinion, there is a priority that needs to be given to disease prevention, especially for high impact diseases, and colorectal cancer is one of them. So this has to be one of the utmost priorities by our policymakers. So there is a need for more funds to cancer prevention, in particular colorectal cancer screening programs. This has to go through providing sustainability to countries where the incidence is going up. We have to think about what Dr. Basu has also mentioned, that colorectal cancer screening colorectal cancer is going up also because of bad habits that we have seen and we have adopted. And of course, providing sustainability and providing funds is also important in light of COVID-19. We have experienced that we have in Italy with the Federation of the society that are dealing with digestive health. We have launched a year-long campaign on colorectal cancer screening during the pandemic. And you know, it worked. It reached, you know, to a certain level. What we need to do, we need to boost campaigns across Europe. We need to have a unified effort. This cannot be left to a single country, because as Professor Van Kutsen said, this is a European problem, is not a country-based problem. And finally, what I think is needed to be done, and I'm not just talking about my country, I know that other countries have the same problem. We need to involve general practitioners, especially for boosting, you know, the adherence to cancer screening programs in each country. And I can tell you that this is something, and we need to work with them, of course. This is something that we have kind of, you know, experienced some problems in Italy, but I know that in other areas, GP's involvement is not there. Finally, if I can take another second, I think we have new technologies. And I know that the European Commission is exploring them through programs, to research programs, to, you know, boost the adoption of new strategies. We can use risk-based strategies to, you know, stratify those who have to undergo colon cancer screening program. There are new technologies like the microbiome can be explored for colon cancer screening in the future. So these are things that we really need to work, because the burden of colonoscopy based on FIT can be very high. And so if we can precisely target the population that need to undergo colorectal cancer screening, will be probably the way forward. Thank you very much.
Thank you very much. Let me bring in John Ryan from the European Commission. We've had a series of recommendations there, as well as the message that, you know, the value of sharing at European level, because no one country has a perfect solution to this. And we also heard a message earlier about the importance of linking upstream and downstream data, and specifically the need for a strong information system. And I'm sure this is strongly resonates with you, because the Commission is going to be launching European health data space. But what can you share with us about, you know, what's upcoming on the Commission's agenda in the next 24 months about both cancer screening and better supporting member states in these very challenging times? John.
Good morning, everybody, and thank you very much, Tamsin, for the floor. From the European Commission's point of view, we tried to gather all of the ideas which might be relevant for a Europe Beating Cancer plan during quite a long consultation phase. We then tried to develop initiatives and actions which we thought would address the issues which people had signaled to us. And the plan itself was adopted then earlier on this year. In the last few weeks, we have published what we call an implementation plan, which basically goes through each of the items in the plan, indicating when and by whom the individual actions will be undertaken. So I can put this in the chat later on, perhaps, so that people can read it for themselves. But the idea is that looking through the implementation plan, you should be able to see in principle which are the actions, who's going to carry them out, and by when. So I think that's an effort on transparency on our part. Secondly, we have put in place a system in the Commission where all of the Commission departments come together to follow the implementation of the plan. We have a similar group with our member states, and we have a similar group with our stakeholders. So we're really trying to be quite transparent on the plan. In respect of screening, the Council of Ministers of the European Union adopted in 2003 a recommendation. It's a piece of soft law on cancer screening, which established the need for population-based cancer screening for 3 cancer sites: colorectal, breast, and cervical cancer. Now, I don't have to tell you or tell the audience that this situation has drastically changed since 2003. But if I might just look backwards rather than forwards, I mean, I remember at the time when the 2003 recommendation was adopted, there was strong opposition from member states, including our biggest member state, because they felt that this was a national problem. It was a regional problem in the case of our biggest member state, and they really objected to the idea that there should be a European standard for anything to do with healthcare. even preventative healthcare. So I think we've moved a lot since 2003. We now have a situation where 20 member states have introduced in their national cancer control plans population-based screening programs for colorectal cancer. So we're much better than we were in 2003 with a situation of 20 member states, but I think we can still go much further. And the Commission is proposing this year and next year, and this work has already started, to revise the scientific basis of the 2003 recommendation. Not as simple as it seems, because of course there's new cancer screening techniques. There's also a lot of evidence, which Dr. Partha has referred to earlier on, which will need to be put into the mix before we come up with a clear scientific opinion next year. And then the Commission will propose a new Council recommendation for the member states to consider. The point about involving health professionals is certainly one of the barriers and limiting factors, but there's also, I think, an issue about communicating with the public on this. And I was impressed by what Professor Logan said about the interface between vaccine skeptics. Perhaps, I don't know if this is evidence-based or not, but the connection between vaccine skepticism, in other words, scientific skepticism, if you like, in a large proportion of the population, and these preventative schemes for screening. So I think there's a lot of work that we need to do about communicating with the public and communicating with risk groups about the need for preventative screening. And that's why we're trying to reinforce the European Code Against Cancer, which is a list of 12 prevention messages, which was developed actually by our colleagues in IARC in Lyon, and which is regularly updated and is a good scientific basis for messaging the public. And finally, then the point which was made by several colleagues in the previous exchange about the need to exchange information on best strategies between health professionals. I mean, we've heard a lot of national experience, regional experience during the conference so far. And I think really putting that in an organized way so that people can learn from each other is another way forward. Thank you.
Thank you, John. And I remember when the council recommendations first came in, as you say, there was a huge battle. Some member states thought that they were already doing very well and they didn't need to be told anything by Europe, and they didn't expect to be dragged down to the lowest common denominator. And others, as you say, said it was not Europe's business. How times have changed, and rightly so. And I think as we talk about, having a fully integrated health data space that would allow researchers, clinicians, patients, and policymakers to access this kind of information, to understand what's being done elsewhere, what's working, what could be adaptable. You can see just how far we've come. Tit Albrecht, if I could bring you in again, you've been around this world for a long time. You've seen the progression. John gave us a little bit of history that it's over the last 20 years how things have changed, and we've been in this accelerated learning phase of the last 2 years where we've had to adapt and learn and understand how to do things differently. As John said, there's messages about communication, how we deal with things, and best practice. From your perspective, what needs to happen nationally and at European level so we can coordinate and upskill everyone to have a more robust and effective colorectal cancer screening program?
Yes, thank you very much for the invitation. And I'm sorry I couldn't follow the first session, where my colleague Dominika already presented also our national experiences and I would say successes, which we are happy to share. I think the Europe's Beating Cancer Plan presents a very good opportunity to try to streamline efforts in terms of screening. We saw John referred to the recommendation, and of course, I often quote the recommendation in terms of it is not a panacea for all problems. We saw from Partha's presentation how varied the response has been. I think that I would take 3 important issues from the current and potential future situation. I think that the burden of the pandemic can best be offset by really supporting the member states with different efforts to launch intense screening programs after the bulk of the pandemic is over. This specifically refers to the member states and countries where they haven't really launched proper population-based screening programs yet. I think there is a lot of funding available from different sources from the European Union to help those member states that might find it challenging. Secondly, I think that one function that definitely lies with the European Union and could be supported through the Cancer Knowledge Center based at the JRC and other mechanisms is, of course, the strive to improve quality. Partha's data, which he shared, which reflect a very uneven quality, warn about the fact that, of course, thinking that we just introduce some invitations to some screening method is not really enough. It's not only even enough if we inform the public, we need to secure interlinks, intertwined systems that will support the data flows and, of course, proper analytical work. This is why every time that when somebody mentions introducing a new screening program in a country, I first ask them about the cancer registry, because how will they manage to measure the impact of the screening program if their cancer registry is not fit for purpose? And I think that what we can use now from all the richness of the data from IARC and from the European Cancer Information System is now showing the successes of the countries that have implemented successfully, and regions, I have to say, and not forgetting Isabel and the Basque Country, that show how you can really make a big difference. It's not something that will happen. You know, many times, even our colleagues sometimes wave their hands and say, oh yeah, we will see results in 10, 15 years. No, we will see results very quickly, and they will not be moderate or minor and then only extrapolated through a long period of time. The third thing, which unfortunately, it's not the right word, I'm sorry, I apologize. The third thing which we do need to take into account, and as much as I agree with Professor Ricciardiello that it cannot be left only to the member states, opinion or choice, the funding, the financing of the actual program is a national thing. So if a country estimates that they have other priorities, of course, they might say, well, it's a nice thing, but then also support gradual development of programs. I remember Malta decided, because they were not able, they did not have the capacities to support colonoscopies, for example, that was mentioned earlier today. They decided to narrow the bracket for the beginning and then build up the capacity of colonoscopies. This is all possible, but don't say, well, we will not because it's too much. We can also build in a gradual way. So I think that my three messages are: communication is definitely, if we go from the grassroots approach, it's not a dangerous process. It's a life-saving and disease-preventing process. Secondly, let's share and use the positive, the successful approaches from our member states and try to spread these practices in other areas. Adding to the communication, I would add another point. There are national specifics. There are minority groups that we need to address. There are cultural challenges sometimes in societies. We need to address all of these. Otherwise, we will lose some populations. There are people who believe that screening programs are always a challenge to socioeconomic inequalities, or they can be challenged by socioeconomic inequalities. If run properly, if communicated properly, they will definitely try to buffer these inequalities compared to opportunistic and random early detection programs. So I do believe that we have an opportunity to boost these programs when the epidemic slows down, and we can support the member states with the bunch of evidence that we have, how successful it can be if properly implemented. Thank you very much.
Thank you very much, Tit. I think that was a really good summary of some areas where the EU can add value and respond. We've had a couple of elements coming up in the chat and the Q&A. There's one question for all the panel to reflect on where somebody said, look, screening programs tend to start at 50. But what do we do with the under 50s where there might be a value in starting to screen, particularly if we're talking about the fact that there will be an increase in lifestyle related diseases where colorectal cancer is a high priority. So how do we explore reducing screening? Does that make sense across Europe? So I'm going to come to the panel with that in a moment. But first, let me ask John a specific question that we've had in the chats. You know, Tit talked about the need to say, you need a cancer registry before you have your screening process. And one of our previous panelists, Iris, said, well, actually, you need both. You need a registry for cancer, and you also need to have a screening registry because the two things are connected, but they're expensive to set up. And for countries that don't have that resources, is this an area where Europe can seed fund or pump prime or help countries move to that level? So, John.
Yeah. So this issue of registries is something we have asked our Joint Research Centre to be responsible for. And in the chat, I put in a link to their cancer information system and also to a specific initiative which they have launched on colorectal cancer. So the documents are there for people to read. What I would say is that the role of the Commission so far, working with IARC over many, many years, has been to improve the collection and quality of cancer registries in general. It's not limited to cancer registries because they also work on rare disease registries in the same context. So we would not be paying for the collection of the data, but we would be paying for all the quality controls which are done at a higher level, a more central level, making sure that the data are comparable. The European Health Data Space, which is something that's being launched at the moment, is an idea to harness new technological tools and new IT systems to improve the quality of data and the collection of data. And I would say this has great potential, and there are European funds, separate European funds, which are available for improving the collection and the analysis of data collected through new IT tools. So I think the registries could benefit from that, provided that they have ideas on where they would like to invest. I would say, in response to what Tit was saying earlier on, it's important that we don't make the situation worse, but that we make the situation better in terms of inequalities. I think it's really important that the Europe Beating Cancer Plan doesn't benefit countries who are already ahead, but that we have a specific focus on trying to reduce inequalities in cancer. And looking at the slides which our colleague from IARC was showing earlier on the countries which don't even have a cancer screening program for colorectal cancer, I mean, this is really where we should be looking in the first instance, I would say. So it's not only a question of registries, it's also a question of the access of populations to organized screening.
Thank you. Dr. Basu and Professor Ricciardiello, can I invite you to respond to this message that we'd had about, what about the under 50s? The screenings exist for 50 plus, but that misses a part of the population who might be at high risk. Dr. Basu, go ahead.
Thank you. There are several different, aspects we need to think about. First thing is, there is a high risk population, say for example, those who have certain diseases, say for example, Lynch syndrome, for them, there is a specific set of guidelines, how they should be followed and then managed. So but then, there is a requirement for education, not only of the individuals, but also the, care providers of the individuals, because the follow-up of these patients are often not adequate. So that's number one. Number two, as already been pointed out, that in the younger population, the colorectal cancer screening incidence is going up essentially because of the high risk behavior. And we have from IARC the European Code Against Cancer, which is an excellent educational tool for the population, and as well as it's an advocacy tool, I would say, for the policymakers, to make sure that people have not only that education, but also the access to the preventive services. So for example, access to to facilities for physical activity. I mean, that's also important. Better urban planning, that itself can create facilities to do cycling. So these are the important things we need to think in terms of the context of overall cancer control program, not just focus on a specific cancer. So this will be my comment on this aspect. Thank you.
So if I can add, I totally agree with Dr. Basu. I think this is there are two aspects that are different. One are the exceedingly high risk populations that have specific management. And regarding the early onset colorectal cancer, we know that this is an issue, already an issue in the United States, and that is why they have lowered the colon cancer screening starting age at 45 years of age. We don't have that information right now, but just one aspect to be added, I think education also making our general practitioners aware that this is an issue that is big, that potentially will become important. So catching up the symptoms, especially with the younger patients, will be extremely important. So expanding the education not only with our population, but also the general practitioner will be extremely important, in my opinion.
Thank you. And we're coming towards the end of our time on this panel. So let me invite each of you to reflect and to give some advice to DICE, the Digestive Cancers Europe, because it's a patient organization and they've convened this second colorectal cancer screening summit. And obviously their focus will be to ensure that every country has a screening process that is effective and robust. But what do you think is the role of patient organizations? What should they start doing as of tomorrow that would help create momentum in the process so that all across Europe we've got a sort of race to the top for effective screening processes? So let me start with you, Dr. Basu, and I'll go through the panel. Advice to DICE, what would you like to see them do?
I think what we need to think about is improving the health system in general, and then prioritize. Prioritization is very, very important. And, as Tit said, a country does not have a good quality population-based cancer registry, but is interested in introducing lung cancer screening. I mean, one has to really think, do a rethinking in that situation. So prioritizing and strengthening the health system across all the different building blocks would be my suggestion. Thank you.
Thank you very much. Professor Ricciardiello, what would you like to see DICE doing or advocating for?
Well, I think as Dr. Basu said, I think prioritizing, making the population aware that cancer and colorectal cancer is a real threat, is a real problem. We need to keep working with the European population, boosting the campaigns. I think we are, in my opinion, I'm kind of fed up with COVID, to be honest. Everybody is talking about COVID. I understand that this is a huge issue and it's the burden right now, but cancer is a burden. So I think we have to work all together, boosting the campaigns and making sure that policymakers, the local governments, the European Commission, everybody understands that this is the utmost priority as well.
Thank you. John.
Yeah, well, I think NGOs have really a crucial role to play. I remember when the original screening recommendation was adopted in 2003, it was Europa Donna, which was holding the pen and behind the whole thing. So, and Professor Veronesi and all the other people who were pushing with the patient groups for cancer screening, and we wouldn't be where we are today unless the patient groups were there behind us. I also think that, as Tit said, politicians also always make decisions based on local conditions and local priorities. And the advantage of having European priorities like this is that you keep a focus for a certain period of time on the topic, and hopefully we'll make some progress this time with the cancer plan, as we did with the previous one.
Thank you. Tit.
Cancer, as Professor Ricciardiello said, did not disappear because of COVID. COVID just came on top of everything else. And after almost 2 years of sidelining other problems, I'm not trying to be unfair to some countries which managed to cope with the pressures, but overall the population is also tired. I think that an organization like DICE can act both ways, through the national levels by supporting patient groups and patient advocates in countries, and of course to continue exerting pressure up towards the international organizations. And I'm happy that we have both EU and IARC here because they've been working hand in hand, and together with the NGOs and patient advocate organizations, I suppose we can also work together in convincing also the politicians how important this is, not only for the immediate future, but for the overall future of our populations. Thank you.
Thank you. And a warm thank you to members of our panel, to Dr. Basu, to Professor Ricciardiello, to John, and to Tit Albrecht, to say thank you for participating and sharing your insights. And I'm going to conclude this panel, which was looking at how we could improve across Europe the colorectal cancer screening.